All right, good morning. It's 9 o'clock, at least in my time zone, so we will go ahead and get started. Thank you everyone for joining us. My name is Dara Albert, and myself, along with my colleagues who are course co-directors, Alex Len, Sarah Lidstone, and David Perez, are happy to welcome you to the advanced course panel discussion this morning. You can see here, today's webinar is going to be a panel discussion that is part of a larger course called the Advanced Course for the Assessment and Management of Functional Neurologic Disorder that was launched just this week. You can see here all of the speakers that are part of this course listed here on the slide, and all of the target audience for the course. If you would go to the next slide for us, please, Robert. So today's webinar, as I mentioned, is going to be a panel discussion moderated by our president of the Functional Neurologic Disorder, Barbara Duretsky. And the first half of the hour is going to focus on the topic of how to put FND on the map locally and nationally. What are some lessons learned? And our panelists will be Dr. Carl Toulemond, Dr. Pretorius, Dr. Wang, and Dr. Tanazi. And then the latter half of this morning's hour will be on topic 2, tips for managing a growing FND clinical service. We'll again have Dr. Carl Toulemond, Dr. Garcin, myself, Dr. Albert, and Dr. Gilmore. And then if you go to the final slide, Robert, thank you. Sorry, there's 2 more slides. So this is the rest of the advanced course speakers. We have a really wonderful panel or slate of webinars and speakers. So please use the QR code in the corner and consider registering for the advanced course. And then one more slide, Robert. Here's some more of our fabulous speakers, and you can see the full list of topics on the FNDS website. Thank you and welcome, and take it away, Dr. Duretsky.
Welcome, everyone, and thank you so much for your interest in the advanced course, as well as this panel we're going to be starting in a moment. I'd like to thank the organizers of the education committee, as well as this course. As Dara mentioned, they put in a ton of work for a fabulous course. I have viewed it, and I can tell you that if you haven't seen it yet, it is definitely worth watching. So I'm really delighted to be part of this as the moderator. And our first panel, you can see here, just going to introduce them, Dr. Crisma Pretorius, Dr. Gang Wang, Dr. Guillaume Carl Toulemond, and Dr. Michele Tenazzi. And so our first topic is how to put FND on the map locally and nationally with some lessons learned. This is a topic that comes up fairly often to us at the FND Society for people excited about FND. And to lead this question, or to give us a response, I'm going to start with Dr. Tanazi.
Thank you very much, Barbara, and the organizer for inviting me this very nice webinar. And at our hospital, we started raising awareness of functional neurological disorders step by step about 10 years ago, beginning from daily clinical work. And since 2015, every week we have multidisciplinary meetings, including neurologists, psychiatrists, psychologists, and physiotherapists, where we discuss 2 or 3 or 4 patients that admitted to our hospital, to my unit. All patients are videotaped with their consent, of course. So it's important also to teach and to see together all the signs. Also, this is important for neurologists, but all professional figures, and mainly also for psychiatrists. We always involve residents also and students from the university in the core teaching. This is very, very important because awareness must start early In our book of neurology, they are not treated. I was invited to treat in a particular book of medicine that we published 2 years ago, but other books are not well treated. I don't know in USA or in other parts of the world if they are well treated, these functional neurological disorders. So it's important also to extend this information not only for medical doctors, but also for all health professionals, in particular also speech therapists and nurses, and also occupational therapists. Unfortunately, in Italy, occupational therapists are still underrepresented. I don't know if in the world is the same, but we try to include them whenever possible. So we tried in this last 5 years also to build this expertise. We invested in postgraduate education. We organized the first master course last year, and now we try to repeat because it was very successful, and also clinical training programs, because this helps young professional move from the basic knowledge to the real clinical expertise in diagnosis and rehabilitation and in semiology of neurological disorder. This is very, very important. Also, if young professionals, in general residents, like to improve their skills, but they don't want to be involved in this topic. They see they have still a bad opinion of this area of neurology. So they prefer stroke, they prefer epilepsy, multiple sclerosis, but in general, not in movement disorders, because a discipline is an area more difficult, because the diagnosis is based mainly on symptoms and clinical signs. But I'm used to tell them that to learn about the clinical signs in this patient, it's important to learn in general neurology. Last, we try to increase the research. We won 3-4 projects, and from the Italian National Ministry of University and of Health, and this was very important because among other, we could disseminate our projects in different peripheral hospitals and at regional and also at national level. And we try also, as I mentioned before, to involve psychiatrists, because in general they are resistant, at least in Italy, to manage this kind of patients. And also it's important because they may be interested in learning about the clinical science that they lost in the past. Neurology and psychiatrists were together, and all psychiatrists were able to examine a patient with neurological signs. Now is not the case. It's not the case anymore. So another thing that we did in 3 years ago, June 2022, we founded an Italian association in Verona, but is a national association of patients, and to support patients, families, and also to connect them with specialists. And this allowed us to approach the politics that are more sensitive to patients, to the association, that with respect to the neurologists or psychiatrists. So, and we received some financing, also because we organized some teaching course for general practitioners, and also we organized ludic events for patients, caregivers, and the lay population. So this is what we have done in this last 5 years. And we try to proceed in this perspective. Now the Veneto region, that with 5 million people and so we count about, considering the prevalence of from 4,000 to 5,000 patients with functional neurological disorders, invested with my group to improve the network and to to realize in the years the steps for a networks and to manage better these patients. I don't know if it was clear.
Thank you.
Clear.
Thank you very much, Dr. Tanazi. That was excellent. I think you being a leading expert is really helpful and key in starting with local experts that reach out with other disciplines, and providing educational resources and answering questions is also really important. With that, I'm going to move on to our next question. So to the panel, locally, did you encounter any obstacles in coordinating F&D activities? And if so, how did you overcome them? I'm going to turn to ask you this question, Dr. Pretorius.
Thank you, Barbara, for the opportunity. I'm from South Africa, and as a neuropsychologist and researcher, a central aspect of my approach has been capacity building in the form of training and mentoring postgraduate students, early career clinicians and researchers to develop sustainable expertise in F&D within our region. And for nearly a decade, I was one of very few researchers working in this area locally, and maintaining that consistency over years, even when it felt quite solitary at times, has now finally been paying off. By the looks, there's lots more people interested in F&D, in doing research in this field, which is really very, very exciting. And encouragingly, younger clinicians and trainees seem to be quite receptive to F&D, and this has also created some exciting momentum recently in South Africa. And then I also collaborate closely with like-minded colleagues internationally, including the International League Against Epilepsy FDS Task Force, and also the International F&D Society. And for example, I serve on the communications committee of the FNDS, and we recently established cultural ambassador roles for people from around the world in an effort to share resources, but also to contribute to cultural relevance and local applicability. And I think this is a wonderful, wonderful initiative, and it helps to bring like-minded colleagues together, which is really, really exciting. Then secondly, there are significant funding constraints. I don't think this is unique only to us. I think everyone has this problem, but this affects both my own research and also the ability to support student projects. And to address this, collaboration has been essential. Again, I work with colleagues nationally and internationally, and these networks provide shared resources, research alignment, and legitimacy when advocating for institutional support. And with funders in particular, we have been more successful when positioning F&D as common, disabling, and cost-intensive when untreated, which reframes it sort of as a health systems and equity issue rather than a niche condition. So the argument shifts from this is rare and psychological to this is a public health and resource use issue. And it seems to work a bit better to frame it in that way. And then thirdly, we do not yet have formal multidisciplinary F&D pathways in most of our public hospitals. So progress have therefore been relationship-based, connecting interested neurologists, psychiatrists, psychologists, physiotherapists, and students to create informal but functional networks of care. But things are changing, which is great for the better. We are now moving from awareness to support and services in South Africa. For example, collaborating with colleagues at a neighboring university to establish support groups for people living with FND and their families. And an F&D clinic is currently in development at my home university, led by clinical colleagues in neuropsychiatry, with my team supporting research and conceptual framing. And then finally, we also work closely with the F&D What Now, which is a patient-led advocacy group, which to ensure lived experiences remain central, because I think that is really central to the work we do as well. We need to acknowledge that and include that work that's been done. So yeah, progress have been steady, patient, grounded in capacity building, collaboration, and a shared commitment to more compassionate care of people with FND.
Excellent. Thank you very much, Charisma. I would just add that one of the other obstacles, because it's so multidisciplinary, is trying to get all the different people together, as Dr. Tanasi said, in their team meetings, you know, their monthly or weekly. We do it weekly. The Zoom and the whole pandemic issue has created it to be much easier. But that is a big one, and inviting people in so that they know you exist for the very tough problems is another important situation.
Absolutely.
If there's no other comments on this wonderful question, I'm going to move on to question 3. Again, this is about F&D on the map locally and nationally lessons learned. Question 3 is, beyond local considerations, what can people do to raise public health awareness of F&D? And how about raising awareness and increasing interest from research funding agencies? Very important. So for this question, I'm going to turn to Guillaume Carl Toulemont, Dr. Carl Toulemont. Please let us know your.
Yeah, thank you for asking and inviting me to talk about it. So, yeah, there are plenty of opportunities to raise public health awareness of FND. So I'm going to talk about our experience in France as we built a national community of practice through what we call the French FND network. Really helped raise awareness of FND, and we learned a few lessons on what action was helpful or not. I'll try to make a long story short, as the French FND network is 7 years old now. So I'll try to be concise. So it all started in 2018 with a collaboration between 3 FND fanatics, Professor Béatrice Garcin, who's a neurologist, Professor Coraline Ingré, who's a psychiatrist, and myself as a consultation liaison psychiatrist. And we shared the same frustration in France that FND was everywhere in clinics, but nowhere in the healthcare system in France. So healthcare professionals were the one interested in FND, often worked in isolation, but medical training was close to zero on FND, and public understanding even worse. So we decided to create something that didn't yet exist, this national multidisciplinary network for FND in France. And so in order to do that, we need to fake it until we make it. So the first step we decided to make was to organize a free national FND day in Paris. So to bring together everyone in France who was already involved with FND or wanted to be. So we did not have any financial support, so we wanted to make it free, one-day event in Paris with expert speakers from neurology, psychiatry, rehab, to talk about FND. So we managed to book a conference room for free in Paris. And finally, we managed to connect and share all the knowledge about FND that we knew at this time, and to launch the French FND network officially. So we managed to gather more than 80 health professionals from more than 10 different specialties at this time. So we're quite happy about that. And at the end of the conference, we presented to the audience the vision and the working plan we had in mind for the network. We had four main axes. The first was to improve medical education. So through continuing medical education courses, webinars online, lectures in national and international congresses, to develop the second educational materials for patients and professionals. The third axis was about promoting multicentric research in FND as well. And the last one was to build a national community of practice to support this multidisciplinary care. So by the end of the day, we had a long list of motivated participants. And from the forms they completed during the conference, we created an Excel sheet with details of all participants, and we sent it by mail to all the network, and then the network was born. So it has been 7 years now, and so I'll try to summarize what we did along this period of time and what worked and what not. So now we are more than 250 members across France, so from more than 10 different specialties. We first started to structure the network because we wanted to integrate an association. So we managed to integrate the French Psychiatric Association called AFPBN by creating a new psychiatric section. So it provided us legal status, a board, and potential for funding. We wanted to identify the network, so we created a logo, an email address, a YouTube channel, and a Twitter account. It was a long time ago, so X account now. We also wanted to make sure that the leadership team remains viable. So we were 3 leaders. So it was kind of a good idea actually, because there was always one available for doing something. And we wanted to have the same vision and the same mindset. So what we told to each other was wanted to dream big and always have fun. So as you may know, Beatrice and Coraline are great human beings to get along with. And we wanted to be able to speak freely to each other because we're managing like a network. It's getting more and more important to make sure that we can speak freely, and more importantly, without ego struggles. That was one of the aim as well. So we set the agenda with regular board meetings during congresses. So we met once or twice a year. We created a WhatsApp group to talk about it as well, and make sure to always inform the others about the new input and output about the network. And we started to create things for developing the axis. So the first axis, as I told you, was improving medical education. So we started with lectures in national congresses about FND in neurology, psychiatry, general medicine. So at first we managed to gather like 10 attendees, and now we managed to organize a full day in a national congress about FND, and plenary session with more than 500 people. So that's getting better now. We create 2 to 3 webinars per year that are available for free on YouTube about FND and ADHD, FND and chronic pain, FND and various subjects. We wrote books about FND in French. We published a national FND guidelines in French as well, because there are a couple of doctors in France that cannot read English yet. So we wanted to make sure that the information will get through this, and we wanted this to be written in French as well, and we share it via QR codes. Last September, we started the first continuing medical education course on FND for psychiatrists and neurologists. So that makes them to connect during the course and share the same language as well, which is quite important for the care. So what's really important in this is that we want to make sure to deliver concrete outputs early in the process of creating this kind of network, to make sure that, well, proof of existence matters more than perfection in itself. The second axis was to develop educational materials for patients and professionals. So patient leaflets that we translated into French, professional handbooks for physio, for psychologists, that we give to the patient for the physio, the psychologist, and so on. Translated educational videos as well. We wrote articles in national media about FND as well to raise awareness of FND. So it helps building this shared language, as I mentioned earlier. make sure patients receive consistent explanations on FND. The third axis was to build this national community of practice. So the Excel sheet is available for all members. So it's free to be a member of this network. Just send an email to the FND network, and then we give you the Excel sheet, and you complete the Excel sheet. And recently, there's a community of patients who was created a couple of years ago, actually. It's named CAPTNF. It's related to FND Hope in a way. And the last axis was to promote multicentric research. And as you mentioned, as you asked, how to raise awareness and increase interest from research funding agencies. Well, we started to publish articles from the French research teams, and then with the French FND guidelines that we published, it supported the need for more research. And so we now managed to get funds from these research funding agencies to start clinical research or clinical projects on FND. So what would be great is to maybe start organizing charities events on FND for fundraising. Maybe it would be helpful to find some financial support, as everything was done voluntarily and without financial support. So it's been 7 years of free time and passion about it. And even though it's been 7 years, the quality of FND care remains quite heterogeneous in France. So we need to keep putting efforts to spread this knowledge. So being patient is another skill that you need to develop when you want to start this network. And it's not recognized as a disorder in France. So it still contributes to the stigma for patients. And we have not yet started to work with the health tech department. We're really keen on doing this.
So Guillaume, I'm gonna have you finish up.
That
was
I'm just
fabulous. I'm surprised, given the Salpêtriers in Paris, that it's not acknowledged as much, but you've done an amazing amount of work. I would imagine that social media or getting patients with lived experience also to join in and speak out, especially maybe ones that are more prominent. So we're going to move on to our last question for this first panel discussion. What opportunities have you found helpful within the FNDS and other professional organizations? And is there more that FNDS can do to help raise awareness at local, national, and international levels? So for this, I was going to call on Dr. Gang Wang to be the first to respond to this.
Thank you. I'm very honored to attend this webinar. I think it's very interesting and meaningful. So today I want to share some information of China FND, especially functional movement disorders, as a highly prevalent subtype of FND. FMD not only cause physical, mental distress to patient, but also lead to numerous diagnostic and therapy dilemma due to insufficient awareness, and this is exactly where our promotion effort start. Firstly, I want to introduce we face a core issue. There remain a significant lack of awareness of FND among both medical professional and the general public in China. Our team conducted a survey covering over 400 clinicians in China, and the results are thought-provoking. Most medical staff have an inadequate understanding of the core principle for FND diagnosis. Over 80% of doctors still regard its emotion abnormality and multiple somatic symptoms as the core diagnosis criteria for FND, while overlooking the positive diagnosis signs emphasized in DSM-5. Meanwhile, nearly over 70% of doctors rely on neuroimaging and electrophysiology, and other examination to rule out organic disease before confirming an FND diagnostic, and over 9% can make a direct diagnosis based on the clinical features. As a result, even when encountering suspected patients, they often fall into the dilemma of daring not to diagnose and not knowing how to treat the FND. Patients often visit multiple departments and undergo numerous examinations, but fail to get a clear diagnosis, and some even delay treatment due to misunderstanding and misdiagnosis. This dual limitation, I think, one is insufficient awareness among medical professions, and the other is a blank awareness among the public. So it's the first hurdle we must overcome in promoting FND. The second I want to introduce, just like Professor Barbara said, how to FND society support some developing country or other country to promote the FND. To address the issue of medical profession awareness and capability, we have made efforts from 3 dimensions. One is training for empowerment. The second is we conscientious for guiding and research for support. Especially this year, we are build academy platform based on the 2025 Renji is my hospital. We call it Renji Neurology Forum. In this forum, we especially invited FND faculty, Dr. Alex Lin, from the Princess Alexandra Hospital in Australia, and Alex have extensive experience in FND clinical diagnosis. So in our forum, in China's neurology forum, Alex explains the typical and atypical clinical manifestation of FND through case demonstration, and introduce in details the physical sign analysis for our Chinese audience, especially the clinician. So it's very great helpful to improve the Chinese clinician to understand and know how to diagnose and treatment the FND.
Dr. Wang, we're going to have to finish up, but that was terrific. I'm sorry if we ran over. We're going to be asking now for panel 2. Thank you very much for panel 1. It was a fantastic discussion. Panel 2, can you bring yourself onto camera? And panel 1, thank you. You can put yourself off camera. So welcome to the second session, and trying to stay on time. Sorry to cut off that excellent discussion from Dr. Wang. This panel is going to focus on tips for managing a growing FND clinical service. This comes up very often to our staff, that people are excited to start program, grow it, and how to manage it. So for the first question of this second panel, what tips would you provide a new clinician working to start a service pathway for FND? And I'm going to call on you, Dr. Gilmore, to lead.
Absolutely. Thank you so much for the opportunity to be here today. For those who don't know me, I'm an early career neurologist, and I just began our FND service in Calgary, in Canada, about 2 years ago. So I'll share with you some of the sort of thoughts and reflections that I have from that process. I think what was fundamental and sort of the first thing that I really had to do was stop and take stock of the resources that were already available locally, and really figure out who my champions were, who had some expertise or at least some interest in FND, and figure out how to sort of build a team around that group of people. I think it's so important for our own wellness, as well as obviously for the care that we provide, that we really prioritize building a team. And so, knowing that there were a few people here and there that were already interested in FND or already seeing patients with FND allowed me to sort of come in and shape that group of people into sort of a more established service pathway. So when I came to Calgary, we already had a group of allied health professionals who were seeing patients with FND and had developed quite a lot of experience. But they were struggling in that they didn't have sort of I don't know how to say it, like an oversight of that program and an opportunity to build it further. And so that's really where I was able to come in and sort of formalize that structure. The other people that I identified as being really important for me to work with were a couple of neuropsychiatrists. One was a neuropsychiatrist who I had met during my residency, and the other, she was just finishing up her neuropsychiatry fellowship. And both were interested in FND, and so I felt it was a wonderful opportunity for us to work together and to provide care for patients. And so I kind of worked hard to get them on board and go from there. I think sort of in the bigger picture, engagement with leadership is obviously vital in order to, establish some funding for these types of opportunities. And so, it was really important to understand the gap in care that currently existed and show that to leadership. And also show them that there are service models, globally that are able to address very successfully these gaps and also reduce economic costs. So I was really lucky to have really amazing leadership that was very keen to recruit me to work with patients with FND and to go from there. And the last thing I'll say is reflecting on sort of the importance of having a champion or someone to drive interest and care for FND. And so I was really lucky in that even before I started, there was a physiotherapist who had started seeing patients with FND and started developing skills. She, attended different educational opportunities, and she really started to build this interest and expertise locally. And then her passion became infectious, and she started, teaching other physios, and then the occupational therapy and speech and language and social work team all became involved, as well as the clinical psychology team, neuropsychology team. And next thing you know, we have this huge group of people with maybe varying levels of interest, but all who have developed expertise together and really enjoy working in that team together. And so that really made my job so easy. So those are my thoughts. Thank you.
That's terrific, Gabriella. You really managed that well with people wanting to learn about these services. So for question 2, how does a clinical service manage the high volume of referrals that are likely to come in once your service starts? And for this, I'm going to turn to Dr. Beatrice Gersin. Take it away.
Yes, thank you for inviting me today. So I'm a French neurologist in France. I'm a neurologist in France, sorry. So I set up a FND unit at Avicenne Hospital, who's near Paris. And the unit offers multidisciplinary assessment to then refer patients to appropriate treatment pathways within our network. We also have a therapeutic education program, and we also offer TMS treatment, which is a very French approach. But because we like data about the efficacy of TMS, we will soon start a national randomized control trial on TNF in FMD. So in our experience, once our specialized FND unit became visible, the number of referrals increased dramatically. Most neurologists were really happy to have a place to send these complex patients. And we now received around 100 new referrals every month, but we can see only about 30 new patients a month, so about 1/3 of the referrals. And because of this, we were very quickly overwhelmed. Patients and professionals are often desperate for help, and this puts a lot of pressure on the team and also a sense of guilt because we cannot respond to everyone. So in my view, there are key strategies to manage this. First, you need to set up clear triage and referral criteria and do it early. I definitely waited too long before setting up this triage criteria, and I had a very hard time last year trying to answer to every request myself. So now our criteria are quite straightforward. The patient must have a functional motor disorder or a dissociative seizure, diagnosed by a neurologist, and he should live in the Paris area. I guess every team should define its own criteria based on its experience and capacities. Second, if possible, have someone dedicated to managing referrals. With the support of from our regional health agency, we recruited a coordinating nurse who now handles all incoming referrals and communication with patients and clinicians. And this was a huge help for me. And third, I will recommend to have a good network, a list of professionals in your area and elsewhere who can manage FND and other functional disorders. So in that way, you can guide patients to the right local care when you cannot see them in your unit. So in summary, triage, coordination, and networking are key to keeping the service accessible and sustainable. Yeah, that's about it for us.
Awesome. Awesome, Beatrice. Exactly. Sustain also the clinicians and accommodate it. So exactly right. So I'm going to move on because we have a lot of more to do. Question number 3. Thoughts on the balance between creating F&D specialty care and working with existing care pathways to bring them up to speed on the new standards of care for F&D practice. And for this, I'm going to turn to you, Dara Albert, Dr. Albert.
Yeah, absolutely. Thank you so much. So I think it's an and, both and, yes, not either or. I think we need to, develop specialized FND programs, but also partner and scale up, our capacity, as my colleagues have just sort of mentioned in their previous responses. One clinic or one program cannot do it all. We do know that patients do benefit from multidisciplinary care and from specialized centers. But again, one clinic or one program cannot see every single patient. It's just not possible. And I kind of liken this to other areas within neurology. Like, we can have our epilepsy centers that see our specialized epilepsy patients, but certainly there are patients with simple, uncomplicated epilepsy that can be managed outside of a multidisciplinary epilepsy clinic. So the same is likely true for functional neurologic disorder, that not every patient is going to need a subspecialized, team. And more importantly is sort of on the education side of things, that we really need to advance, as many of my colleagues have mentioned this morning, like the general knowledge, both in the public and in the healthcare realms across many different disciplines and specialties, some awareness of FND and some, basic understanding. I mean, imagine a world, I would love to live in this world where every clinician that our patients come in contact with have some knowledge, like, yeah, I've heard of FND, not like I've never heard of this, have some basic understanding, yeah, that's a neurologic condition and I can point you in the right direction, even if I can't treat you myself, and some compassion. Like, yes, this is a real disorder. It causes real distress and disability for our patients. And these patients deserve to be treated with compassion and understanding, just like every other diagnosis. And I think the way that we, at least part of the way that we get there is through branching out. So not just having these subspecialized clinics where all of the patients come to us, but branching out, education for everybody, scaling up, around us, not just in a single specialized center. So yes, and.
So that was terrific. I would also say that supporting other clinicians who want to help but just are stuck and don't know what to do, and Sometimes you can invite them into your team discussion for the complex care and tips that I learned so much about, as well as just making sure that they know when they can send them in, or being part of the bigger team, staying on the team, reaching out to all the different clinicians that are involved in the patient's care, some that are on board and some that are, you know, really not as knowledgeable, and maybe sending the patients for more tests and things like that. If anyone else has any other comment before I move on to the next question, I'm open to it. Okay, I guess not. Thank you so much, Dara. That was great. The next question, where does psychiatry fit into the equation? And how about physiatry? And for this, Guillaume Carl-Toulemont, Dr. Carl-Toulemont, for you, this question, I'll start with you.
Again, thank you. I really like the term physiatry. It's kind of a great resume of what we can do as a psychiatrist really interested in FND. So if you want to start a private practice on FND as a psychiatrist, the best advice would be start your private practice. And you see there's many patients, and make sure you're well surrounded by a great network with trusted neurologists, rheumatologists, internists, because I'm sure that as a psychiatrist, we are helpful for the patient, but we are not in position to give the FND diagnosis. So it's good to make sure that we position ourselves well in this care program. So I started an integrated clinical care program when I moved from Paris to Toulouse in 2022, and I set my private practice in a general multidisciplinary clinic in Toulouse called Saint-Exupéry Clinic. And I do not regret this move, as it's essential to work with neurologists around, rheumatologists, internists, rehab services, and so on. So I work with a medical assistant who's a nurse specialized in psychiatry and neuromodulation, and I have around 600 patients in my active caseload. So how can a psychiatrist fit into this? So first, as I mentioned to the patient, that I'm a psychiatrist first, so I'll take care of psychiatric comorbidities, make sure that in the first assessment, we manage to find some of these. Second, I'm a psychotherapist and FND specialist, but as I mentioned, I will never be in charge of giving the FND diagnosis. So the patients are referred to me after having been diagnosed with FND or chronic pain syndromes, as I take care of this patient as well with neuromodulation techniques. And after that, I start the first session with a specialized neuropsychiatric evaluation, assessing the presenting problem, the predisposing, precipitating, and perpetuating factors of FND, the psychiatric comorbidities, and so on. I always check and take the time to show the positive signs of FND. Even as a psychiatrist, we can assess the physical symptoms of the patient, and it's good to be trained for that. And I always thank my neurologists, teammates that taught me that, and make sure to explain the diagnosis again to the patient, because sometimes they get the first information, but it's always good to check on this. Then they all complete a bunch of questionnaires beforehand, and I include them into a research database that I built straight at the beginning of my practice. And once done, so it takes 1 to 3 sessions, 30 minutes long, to do the assessment, and then I define the treatment plan with the patient. So I associate CBT, schema-based psychotherapy as well, so working on abnegation or self-sacrifice schemas, perfectionism, and so on. Emotion regulation as well. So I make sure they are involved in the FND-based physiotherapy program as well. So I always refer them to a physiotherapist with some specific handbooks for them. I refer them at the same time to the psychologist, a speech therapist if needed. And I set several sessions of transcranial magnetic stimulation. So I've got the device right behind me. And so I use it as a sensory motor feedback modulation, so mainly for FND motor symptoms. And I use this tool as a starter to help the patient experience a physical change in his symptoms. So by stimulating the primary motor cortex according to the symptoms, obviously, above the motor threshold, meaning that I aim to generate movement of the disabled limb, for instance. And I make sure the patient is aware of the movement and help him focusing his attention on the moving limb or the feeling of the impulse provided. So from my experience, it helps as a proof of concept of what I explained to him before, or to the patient before, about the pathophysiology of FND. And I also give psychoeducation tools that we created with the French FND network, obviously. I make sure to treat psychiatric comorbidities. As a psychiatrist, it's obviously interesting to have this opportunity to treat psychiatric comorbidities, especially because they are full of stigma, these patients, and they do not really want to be referred to a psychiatrist. They always are afraid of being considered as crazy and so on. So using this medical device is also a great tool to mediate this relationship with the patient and make sure that they come here first to get this medical treatment, but also they see a psychiatrist. So I always take care about the psychiatric comorbidities at the same time. So physiatry, I think, is the best term for this. The mean follow-up for the patient is 1 year, and it worked quite well because around 75% of patients report clinical improvement within 1 year in my private practice. So I decided to start small, and I keep it small because I don't want to burn out, obviously. And as I just receive them here, but if needed, I can ask my colleagues to hospitalize them, as this is a multidisciplinary clinic. So there's a rehab unit and there's an internal medicine unit as well. And using these combined interventions in a structured care program really helps treating the body first, and then with the help of a medical device, obviously, and also making sure that the patient lower their defenses about this fear of being seen as crazy, as I mentioned before. So what maybe didn't work is that I keep struggling with recruiting well-trained professionals in my local network. I'm quite isolated here in the southwest of France, so I keep on trying to put some training programs locally. And as mentioned, all my colleagues here today, triage is one of the things that we need to do, because there's so many referrals that we cannot afford to.
Thank you very much, Guillaume. We're going to probably start to move on. I would say the psychiatrist is also very helpful for the other team members when we get stuck, and extremely helpful to move the neurologists and physiatrists we call rehab specialists as well, which is part of the question, which an important part of the team. But if it's okay, I'm going to move on because we have a couple of more we might be able to get to here. I'm going to ask the next question. Should programs start with one FND subtype or work across various FND subtypes, particularly since mixed symptoms are so very common in this disorder? And maybe to start us off, maybe you, Dr. Albert, would like to take this question.
Yeah, so again, I'm going to say this isn't necessarily an either or situation. You got to kind of start with what you have available to you and what the expertise is in the place that we're getting started. So I'll give you the example of myself and my team. So I am trained as an epileptologist, and so my expertise lies in like differentiating epileptic seizures from things that aren't epileptic seizures, including functional seizures, but other things that are not epileptic seizures either. And so it works really well to have me involved in that clinic when somebody is presenting with seizures to, I can carefully review the semiology, look at videos, if there's EEG data to go over, and I can really give that, second opinion to that patient or their family about like whether their events are epileptic or functional or something else. And I, speaking for myself, have less knowledge and comfort doing something similar with, for example, movement disorders, although I can recognize tics and common things, but like some other more rare movement disorders that my colleagues that have that expertise would be better able to differentiate what is a physiologic movement disorder versus a functional movement disorder. So you have to kind of start with what your expertise is and what your knowledge is and build from there. So our program, does focus more on the seizure presentation, but we will absolutely see patients who have mixed symptom presentation. So they have seizures and also other, FND symptoms, and we can certainly address multiple symptoms. And I work in a multidisciplinary team, so we can tackle other things as well, but we focus primarily on the seizure presentation.
So, Beatrice, did you want to add to this discussion? You're on mute. Unmute yourself.
Sorry. Yes, I wanted to add my experience because I myself, I am trained in movement disorders and dementia. So I started with functional movement disorders and then functional motor disorders. And now I expanded to any type of FND. And in my view, there is a huge benefit in managing several FND subtypes rather than focusing on just one, because symptoms often overlap, as you said, but also because it actually really enriches clinical practice. For example, I want to give 2 examples. For example, by applying the same clinical examination to all patients, we realized that positive clinical signs that we observed in functional motor disorders can also be observed in patients with functional dissociative seizures, and this can really help for the diagnosis. And on the other side, we really improved our management of motor disorders by using grounding techniques that are originally developed for dissociative seizures, but they can be really helpful in patients with paroxystic movement disorders. So I have a different view, and I wanted to share this experience.
Yeah, and you become better neurologists by practicing it, and maybe your patient then develops movement and you don't have to keep sending them around. You can just say, I'm going to send you to see the rehab physicians and the physical therapists. Excellent discussion. So for the last question, since we only have a few minutes left, and I've learned so much, I'm really enjoying this panel. Thoughts on the treatment setting. So many of us here work in the outpatient setting. We've been hearing about this, but there's also inpatients. I recently spoke at a hospitalist meeting for all inpatients, and I had to sort of rethink how to approach that. So should there be different pathways, and how do you manage that? I see, Gabriella Gilmore, you have your hand up.
Yeah, I'm happy to comment on this. I also work predominantly in an outpatient setting, and our current pathways are outpatient pathways. We have sort of an intensive 5-day outpatient program, but our team has definitely been battling with the fact that that 5-day program isn't sort of sufficient for, I would say, a small minority of patients, but a handful of patients who are highly motivated to participate with us, but just need, a bit more of an intensive approach and would really benefit from that inpatient sort of pathway. So we've been sort of toying with that idea and starting conversations with leadership to understand if having sort of an elective outpatient an elective admission for a defined period of time might be possible to allow us to administer or provide some of our various rehabilitation and psychological therapies in a more intensive way. I would say, however, generally speaking, for the vast majority of our patients, I prefer an outpatient setting. I think that it allows patients to take what they learn from us and practice those skills at home with their families in the environments where they're experiencing symptoms, and is really important for developing agency and prioritizing motivation.
Thank you. I'm going to add to that because we do have an inpatient program. It's very specialized. Ginger Polich, who's a physiatrist, a rehab doctor at Spalding, does it from inpatient. There's a lot of criteria there that need to be met. Patient has to be given the definite diagnosis, not on a path of finding more testing, agree with it. And it's really focused on gait and motor. Because the inpatient seizure programs are challenging. People have seizures and then all of a sudden they get shipped back to the ED and it doesn't really work very well. So that is one format. And there are some programs throughout the country that some patients who are very ill may benefit from, but it's usually acute. It's not like somebody who's had it for years. It's shortly after they get it and trying to get them on the right path. Any last comments? Because we're at the end of this hour already, which I can't believe went really
just one
super
thing,
fast.
that
Michele.
just one thing, Barbara, that I think that is very, very important, is to collaborate with other group in the other topic of neurology, you know, so to spread the knowledge of FNE. It's important to interact with the outpatient clinic of pain, of epilepsy, of course, but of movement disorders and multiple sclerosis. This is very, very important because, you know, I don't think always to have money, but it's important to involve other people that are not focused only on FNAD. So I think that this is important also at the local level to spread our knowledge to different groups. Now
Absolutely.
I'm
Absolutely.
doing this with my groups, with my different groups.
It's a great way to end. It is multidisciplinary. It's everywhere, and we're all doing so much to help. So I just wanted to close and say thank you. First of all, to the course directors, Dara Albert, Alex Lynn, Sarah Lidstone, and David Perez, to all the speakers that you will go back and look at. There's an amazing rehab advanced course for you to look at, and to all the panelists here today that took time out of their day. These are truly high quality talks and sessions, and hopefully you've learned a lot. This closes our panel for this morning or this afternoon or this evening, or wherever you are, and hope you have the rest of the day or weekend ahead of you. Thank you very much.
Thank you so much, Barbara and Dara.